Good. They come together. What is the lateral root of the lateral cord carrying? See, 5, 6, and 7. That's what it's carrying, right? And then what is the medial root of the medial cord carrying? C. So you would think it'd be C5, C6, C7, C8, C1. But it is, but the C5 is so minimal that most anatomists discount it and don't count it. So if you look at most anatomy, not all anatomy books, but most of them will consider the median nerve to be C what? C1. There you go. So it covers a lot. Okay, it's not as easy as the ulnar nerve, which is primarily C1 because the ulnar nerve is the terminal branch, direct continuation of the medial cord. In the medial cord, yeah, but why? Why is it CAT1?
CAT1 nerve.
Yeah, because, but what? Yes, true. But why? Go back. Yes.
The anterior division of the lower trunk.
Bingo. Anterior division of the lower trunk. And the lower trunk, remember, is formed by upper trunk is C5, C6, middle trunk is C7, lower trunk C8. Okay, so again, going backwards, you can find the origins, and it's so helpful. So you know pretty much everything the ulnar nerve innervates is going to be CAT1. Now, you know there's always these little exceptions, right? Like C7 somehow could sneak in there as well. But anyway, we're not going to worry too much about that right now. So median nerve, you guys see? Almost ready. You can see. The medial nerve, all these nerves are going to kind of run down where? Well, let's back up. So scalene, what two heads? Anterior medial head. That's where the brachial plexus is going to come out of initially, right? And then it's going to travel down, and then there's some of these branches formed by what? The roots and they come off the upper trunk. Those are called what kind of branches? Supraclavicular, because you're above the clavicle. Once you get to the level of the clavicle, you get into the divisions, and once you get below it, you're getting to the cords. Okay, so we're talking about the cords now. Okay, so it's going to be under the clavicle, and then where does it go? Under the pec minor, good. Okay, and then ultimately, look where I'm going. Pec minor's over here, where I've taught you that, right? Coracoid process, coastal cartilage of ribs 3, 4, and 5. Okay, so you can feel the coracoid, you know where the ribs are. So we're in this area. So now we're going to be coming, it looks like, it's coming down this way, isn't it? That's where the pec minor is. So it's not going to be going like this. It's going to be coming on the inside of the arm. Okay, everybody with me? And then in relation to the axillary artery, where's it going to be? Lateral. Okay, and the way I always remember it is you can feel your pulse, right, in the brachial artery, which is the continuation of the axillary artery. You can feel it. So I just remember, okay, if you can feel it, that must be medial, and the nerve must be lateral. Okay, so down it comes, and then everybody feel your medial epicondyle, okay, and then go up about 2 inches, up proximal 2 inches, and this is called your lateral supracondylar ridge. Bear with me? Okay, so not in all people, but in some people there's a spur there. And a ligament comes from that spur down to the, what? Medial epicondyle. And what's that ligament called? Anybody know?
Ligament of Charles.
Yeah, okay. Now, how do you know that?
Anatomy.
Oh, you already had it. Yeah, well, not many people say it. They must have already had it. Yeah, and okay. And again, not everybody has the spur. Not everybody has even the ligament. But you know, those that do are going to be more susceptible to being impinged as it goes through that osteofibrous tunnel. Okay, osteofibrous tunnel. There's just bones there, and it forms a tunnel as the nerve goes through there. Okay, so that's one potential point of impingement. Okay, then where's it going to go? It's going to enter the
Cubital fossa.
Good. What part? Medial, lateral.
Medial.
Medial cubital fossa. Whenever you hear the word cubital, think of
Elbow.
elbow. Think cubital, like cubital tunnel, cubital fossa. You hear the word cubital, think of elbow. If you think carpi, think of wrist, and so forth. Okay. So once you get into that medial cubital fossa, once you're in this area here, there's a couple things to consider. One, there's 5 branches that are going to be put off. 3 motor and 2 sensory. Okay, go back to this. If we do this, everybody do it on yourself. So the pronator teres, move your finger, good, your index finger. Move your middle finger, which is your carpialis, and move your ring finger, that's your ulnaris longus. So it gets 3 of the 4 superficial muscles. The 4th one is way over here on the ulnar side. Where is it? On the ulnar side. So what nerve do you think hits it? The ulnar nerve. It's called the ulnar nerve because it runs on the ulnar side. Okay, so you kind of 3 of the 4 superficial muscles and the intermediate muscle, which is what again? What's divisor superficialis. So it's going to get all of those muscles. Okay, everybody clear on that? Okay, so we're at 4 muscles. I say 3, 4 muscles, and then that's it. That's all I want to say there. Okay, now in that area, cubital fossa, medial part. Remember what I showed you a second ago? The biceps comes down, and then what goes in the opposite direction toward the ulnar side, like right here?
Bicipital aponeurosis.
Yes, everybody kind of do that on yourselves. That's where it's at. And it's also known as the lacertus fibrosus. Sometimes that can get thickened, and it can put pressure on the median nerve, because that's where it's at, right? The median nerve is right there. Okay, so that's one of the ways. How do you think you can maybe test to see if there's any symptoms? Well, how about flex the biceps in a supinated position, right? And that's going to tense the bicipital aponeurosis. And if there's a problem there, that could potentially impinge on the median nerve. And you can get Lacertus syndrome. What's it called?
Lacertus syndrome.
Okay, good. All right, so there we've got 4 of the muscles taken care of. How many are left?
6.5 or 2.5.
Good, 2.5. Okay, how many are left again?
2.5.
2.5. How y'all doing?
A-okay.
There's your 2.5. Flexor pollicis longus. Lateral half of the
Flexor
profundus. Lateral half, so only half. That's 1.5. And then
Pronator
pronator
quadratus.
quadratus, right here. Okay. Okay, that's how you remember it. So you remember do this to remember the 3 superficial muscles, and just remember the one on the ulnar side must be the ulnar nerve. And then the one deep is also done, so there's 4 motor branches. Okay, 3 superficial motor branches, and then 1 intermediate. And then what? Okay, now let's continue our little merry way. Okay, all these nerves, all 3 of them, go through 2 heads of a muscle. And that's a good thing to remember too. Now, whenever it's going through 2 heads, if you have a lot of repetition and contraction of those muscles, do you think it's possible to, compress the nerve and irritate it? Yeah, so people that do a lot of, let's say a lot of pronation, supination all day long with screwdrivers and using tools, well, the pronator teres is working pretty hard, okay? And especially if they're not used to doing it. So they have work around their house, and they usually don't do any work, period, of any kind. And all of a sudden, their husband or wife, whoever is going to do the work, does it all day long because they want to get it done. And all day long, they're doing this. Okay? You think it could be a problem? Yeah. So the nerves, the muscles that used to contracting, the nerves that used to being compressed, and that repetitive compression can irritate the nerve and lead to pronator teres syndrome. Okay? Pronator teres syndrome. Okay? So that's one of the possibilities. But sometimes, interestingly enough, and I'll show you this in a PowerPoint next week, sometimes that can get confused with Lacertus syndrome. And you have to be able to differentiate. And it's not always easy to do. Okay, so keep those things in mind. What are the places of possible problems? In the bicipital aponeurosis, or the Lacertus fibrosis, or as it goes through the 2 heads of the pronator teres. Okay, good. As it's going through the 2 heads, a branch is going to come off of it. And what is that branch? Anterior osseous. Okay, so if you're doing this all day long, you could possibly also injure the anterior interosseous nerve. And that can give you anterior interosseous syndrome. Simple little test to know if you've injured that nerve is when you say, "How y'all doing?" And you have your patient make a circle sign, and they do this. What's different?
No flexing.
Yes, I'm not bending the distal joint. You see how I'm bending it to make a nice circle? They're doing this. It's flat. They can't bend it. You guys see that? So that's your sign, anterior interosseous sign, that nerve is damaged. And then you can break it down. And that is a motor nerve only. So is there going to be any sensory symptoms? Nope. That's why this is the test. This is the test. Okay, now, of course, you could do other things like look at their strength of these individual muscles. Of course, you could do that too, right? But this is the sign you look for first. Make a nice circle like this is what you tell them. And they try to do it, and no matter how hard they try, they can't. And they end up doing this. Then you know pretty much for sure, without a doubt, that they have anterior interosseous syndrome. Okay. Now, it can get a little more confusing and more difficult. Wonder if you have an injury in the Lacerda syndrome. Could it also produce this? Yes, because everything distal to the injury is going to be affected. How about under that ligament of Struthers? Yeah, that could happen too. But here's the difference. You're going to have sensory as well, most likely. Okay, with anterior interosseous, you're never going to have sensory, ever. Okay, so that's where you're a troubleshooter. Okay, and then it's going to continue down. It's from there, once it goes through the two heads, the median nerve is going to travel under an arch of the flexor digitorum superficialis. How many heads does that have? It has two, too. So whenever you have two heads, it can form these fibrous arches called arcades. Oftentimes. And it can be a source of impingement. So it can be impinged there. Okay, so there's 1, 2, 3 areas of impingement. The Lacertus area, through the two heads of the pronator teres, and the fibrous arch of the flexor digitorum superficialis. Then it's going to travel down between the flexor digitorum superficialis, superficial, to the flexor digitorum profundus, which is deep. It travels down its merry way, then it's going to kind of course laterally. And ultimately, it's going to end up at the wrist. And that's where we're going to stop. Now, where does it end up? If you kind of cup your hand like this and flex your wrist a little bit, not everybody has it, but there's a palmaris longus there. And it's absent in 10 to 15%. I forget the exact number. But anyway, it's absent in a certain number of people. Okay? I don't have one on my left. See? But I have one on my right. How cool. Okay? And so look at yourselves. Cup it on both sides. It should pop out right in the middle of your wrist. If you have a tendon right in the middle of your wrist, then you have it. If there's not one there, like there's not one for me, then I don't have it. Then you don't have it either. Does anybody not have it? Raise your hand. Okay, one. Who? Two?
No, I'm just.
Okay. Well, 1, 2 for us two, right? So, so there's a certain percent that doesn't have it in both sides. 10, 15%, whatever it is. I don't remember offhand. Not important. Okay, just realize that not everybody has it. Okay? All right.
Raphael?
Yes, sir, please.
If I can add clinically to that.
Yes,
talking about
please.
nerves and stuff. Clinically, the palmaris longus is the tendon that they use for reconstructing UCLs. So if you don't have either one, you can't have a UCL, I guess. You can still use cadaver, but they harvest that palmaris longus for your UCL graft. So something that you may see in clinic if you ever see UCLs. And you'll see 2 little or 3 little small incisions where they harvest the palmaris longus tendon.
Yeah.
And then they'll actually double it over and make it the right length, and then do the modified docking technique, which is the most common one now, but that's for another time.
Yeah.
Yeah.
How cool is that? Yeah, when we get to my special presentation on the elbow, I think I still have my picture of that exact same thing. Show you where they make an incision here, they make one there, take it out, cut it out, and away they go. How cool. Fun, must be fun being a surgeon. Okay? So So where's it going to end up? It's going to end up between the palmaris longus and what's the tendon just lateral to it that you can feel?
Flexor radialis.
Flexor carpi radialis. So that's where it's going. Okay? That's where it's going, and then it's going to enter the hand. We're not going to get to the hand. We'll save that. But that's at the forearm, and that's as far as we'll go today. So I want you to practice with each other.